the one thing I learned in medical school from a professor of medicine, I stay with me all my life. It's why I do what I do. And he said, with apologies to Descartes, I doubt, therefore I am. So Descartes said, I think, therefore I am. I doubt, therefore I am. So whenever I hear assumptions, I always challenge assumptions. So I'm going to challenge the panel. And there are a number of assumptions that were made in all three presentations that I think are worthy of exploring further. So I'm going to be a little bit of a iconoclast. I don't know. I'm just going to take pot luck and see what happens, just to stir it up a bit. So maybe I'll start with the last presenter working our way up. I was one of the first people that ever used cisplatin in clinical practice. It goes back to 1973. And I've been using it all my career as an oncologist. And I think the number of cases in adults that I've seen who have had hearing loss that has required the reduction in dose of cisplatin, maybe one. And I also was responsible for those publications on dose intensity chemotherapy. And one of the drugs we concentrated on at the time was cisplatin. Very narrow therapeutic index. I mean, if you drop below 25, 18, between 20 and 25 milligrams per meter squared per week, you start losing fat. It's really a steep curve. So when you start dropping the dose of cisplatin based on subclinical hearing loss, you compromise patient outcomes. So my question to Bruce really is, in children, I can see the argument very, very clearly, because a lot of these kids will be cured, they have long life expectancy, and we can appreciate why this is so important. My question is, the assumption that this applies to adults and is going to have significant clinical utility, I need to just ask you, what is that based on?
Okay, well, a couple of things. First of all, I'm not assuming, is this microphone on? Can you guys hear me?
Yeah.
Okay. So I'm not assuming utility in adults, although I would suspect that there is some relevance. So again, using the argument that in pediatrics we take adult data and we child size it, for lack of better words, I would say that the same ought to be true in this case until proven otherwise. But we're not just sort of saying, well, we assume that there's value. We're actually looking for this. And the population of adult patients getting cisplatin that we're looking at is actually testicular cancer survivors who've been treated with cisplatin. So what's the incidence of hearing loss that's due to cisplatin in that population? This actually came up at one of several meetings at FDA. I'm now an advisor to the FDA's advisory committee on pharmaceuticals. So they have, this came up, and the oncologist, the adult oncologist said, we already have a test for neutropenia. That's what we use to sort of guide cancer chemotherapy in general. We don't need another test to look at hearing loss. It confuses the issue. And I'll tell you, the patient advocates were quite angry about that statement, almost fell off their chairs, and said, please don't just assume there's no utility, or don't assume that we don't need this. We want more information about all the risks and all the benefits associated with chemotherapy. It's not for you to decide which adverse effect is relevant or not. And again, I agree with Dr. Levin that its utility in adults is going to be less relevant than in pediatrics. The question is, how much less? Is it enough to warrant no testing in that population? I don't know the answer yet, but we'll find that out. I've got almost 90 patients with cisplatin-induced hearing loss, adults, that we've recruited at Princess Margaret, Kingston General Hospital, and the BC Cancer Agency here. These are adult patients, and about 200 controls. And so we'll look at that question. So I think that if the issue is don't assume, I completely agree. We're doing the work. And we'll look at relevance. I think it's very important in both populations. And not just in pediatrics and adults, but also in a wider catchment of the rainbow of patients that we see. Okay, Okay, this is an immigrant country, so Northern Europeans are relevant, results are relevant in some, but not in everybody. And increasingly, in British Columbia, 13% of marriages are of mixed racial backgrounds. So, you know, I have a lot of patients that come in and say, I don't know what my ancestry is. My dad's East Indian, my mom's Persian. You're both. That's the neat part about this. So we need not only population-specific genetic tests, but we need to understand the incredibly diverse ancestries that an immigrant country creates.
So Chris, I'm not going to pick on you, but I just want one additional question. And that is, you know, the application of a genomic test, a genetic test, what is it in this case?
Genetic
test, yeah. In the context of other tests that are available, why is this test better than sequential audiometry testing?
So again, I didn't, because Brad only gave me 20 minutes. I didn't put in our receiver-operated characteristic curves, but basically you can see that clinical data is a predictor of hearing loss and of outcome. You can use, you know, smaller children more likely to have hearing loss, etc., higher doses, etc. But what you find is that by adding genetics, we go from about 60% of the area under the curve to 90% in our ROC curve. So it adds value. And again, it just better characterizes risk-benefit profiles. I was at FDA 2 weeks ago, and I was talking about risk-benefit ratios, and they said, please don't do that anymore. Because a ratio implies that you know risk and you know benefit. You can assign numbers to that ratio. We can't do that yet. So talk about reducing the uncertainties associated with drug use, the uncertainties of whether drugs are effective or drugs are safe, and in what way. So it's risk-benefit profile. So I think it advances that. The question for a technology assessment group, and we have them in BC, and I, of course, sit on CDAC nationally, looking at drug technologies, you know, is this relevant? Is this cost-effective in a specific population? So again, what I suggest is that we don't need to be asking whether genetic testing is valuable or not, as much as we need to know in whom it is valuable and to what degree. And that's what I hope that this pilot program will help us answer.
Any questions from the floor for Bruce? I'll ask another one then. Risk stratification using your test. You spoke at a low-risk group. Are you in a test where it's possible to go beyond the cumulative dose of 450 milligram per meter squared for doxorubicin in adults for those people who are low risk?
Right, so I guess the question is, because we know the cumulative dose of anthracyclines is related to the development of cardiotoxicity, but if you look carefully, even at the adult data that that's derived from, or the pediatric data, there are patients that are susceptible at even lower doses than the threshold. So I guess is your question, would you test patients that are low risk?
The question is, would you do a test for cardiotoxicity?
Yeah.
If you've got a low risk profile, a low risk test, would you then do clinical trials to evaluate whether those people who are low risk can tolerate higher cumulative doses of doxorubicin, which is an important question for responders at 4, 5, 6 cycles of doxorubicin. You want to go beyond that. At the moment, many of us stop at 450 milligrams per square.
Yeah, I think that's exactly right, and that was sort of what I alluded to, the lowest group, whether or not those patients, if diagnosed, if they have, for instance, stage 4 disease at diagnosis, whether they should be getting higher doses. If they test low risk, you could suggest that perhaps they should. Again, I think that has to be evaluated. Any of these issues that I bring up have to be tested before we start, you know, reducing doses and monkeying with chemotherapy where we know the defined survival curves already. But I think that absolutely, I would think that testing can be very useful. In some patients that get very low doses, for instance, as adjuvant chemotherapy for breast cancer, I'm not so sure that testing is necessary. If your risk of cardiotoxicity is low because of the dose you're using, do you need to test? I think that's an issue that our health economists will help us look at over time.
A number of you use risk stratification. These are diagnostic tests. So, Ali, you mentioned the risk stratification for FLT3 absence of NPI. That sounds really great. Would predict for chemo resistance. How do you know that that low risk, that group, which is high risk for relapse, how do you know that that doesn't characterize chemotherapy resistance? In other words, the reason why they're doing badly, because what concerns me is that you identify a high-risk group for relapse, and then you design a study to give them more intensive chemotherapy. But in fact, the reason why they relapse is because your genetic test has predicted for chemotherapy resistance. You've made there's almost an implied assumption there that the identification of risk for not doing well means that you can treat these patients earlier on with stem cell, not stem cell, with marrow transplant, etc. How are you going to tease that out? Cause-effect relationship.
So unlike Bruce Brack, 30 minutes, but that's because I speak slower and provide less information. So I did not show the slide. I alluded to it, that there is lots of evidence from multi-center trials that providing stem cell therapy to those patients that have a FLT3 ITD mutation and are NPM wild type actually brings the Kaplan-Meier survival curves level with people who get chemotherapy and only chemotherapy who don't have that mutation. So there is evidence already provided. But so to take your question further and say, well, as you identify new markers that predict for survival, how do you know then that it's not predicting for chemotherapy resistance, as you're saying, as opposed to something that'll help you? And those studies will have to be done. So, which is why we're engaging sort of international partners to look at this. You need large numbers of patients to determine the answer.
So I'm going to be really provocative, and then I'll leave the town workshop. So I'm going to be a little bit provocative here and go out on a limb. How many of these tests are going to change clinical practice without clinical trials to validate the test assumptions? In other words, how many of these tests are just tests looking for a place to go in clinical practice? To what extent are you going to insist on the rigor of clinical trials to validate the assumptions on which the test is being derived or being produced? What really worries me is that to identify these changes, which are brilliant, by the way. I think all the work that I've seen up here is absolutely outstanding. So please don't take my marks out of context. But what concerns me is that more and more these tests are going to hit us because you guys are so good at what you do. But you're ahead of the treatment curve. You're ahead of the clinical reality of what we're facing. And to what extent are your tests going to drive clinical trials? And to what extent will your tests kind of make it a shortcut for oncologists to say, well, this makes sense, I'm just going to do it? How do you address that? Because you are ahead of the curve. I mean, you guys are, it's like the horse before the cart, then we've got to come and catch up to what you're showing us. And the nature of the clinical trials design, the assumptions that you're making need to be tested in real time, and you're there chomping at the bit saying, come on already, fund the test. And if you fund the test, policy decision makers are going to say, well, yeah, if we fund the test, what are you going to do with the test? And how is it going to change clinical practice? Or do we have to wait for the link between the test and the clinical reality to be established? It's a general question to the whole panel.